Honestly, renal is one of the systems where it is most useful to read the last line of the question stem first before you read the entire vignette. And oftentimes the questions will be asking you to solve something that's really specific that requires the labs, or to parse out some specific little piece of information that will just help you solve the question right away. Either way, I always advocate for reading the last line of the prompt first to guide your approach to the question. Another action potential mentoring test taking tip. Renal is one of the topics that will still highly test your pathophysiology on step 2 and step 3. You have to know some of those nitty-gritty details in order to get these questions correct. So make sure you fully understand the pathophys and pharmacophysiology for this section. All right, let's start off with FENA. And so to calculate FENA, it's your urine sodium times your serum creatinine divided by your serum sodium times your urine creatinine. You have to write out this equation a few times to make sure that you know it. And so how I kind of keep it in my head is I know that you're going to have a sodium and creatinine in the top of the numerator and then a sodium and creatinine in the denominator. And you just got to remember that they're opposites of each other. So it's the urine sodium and then the serum creatinine in the numerator, and then the serum sodium and the urine creatinine in the denominator. All right, so once you got that memorized, you can move on. And so if you see a FENA that's less than 1%, you're going to think it's a prerenal azotemia. And this will be supported by a BUN to creatinine ratio that's greater than 20:1. If you see a FENA that's greater than 1%, you know that you're looking at either an intrinsic or a post-renal azotemia. And so here's a little cheat sheet for working up AKIs on the USMLE. If it's prerenal, you want to see if there's physical exam evidence of volume depletion. If yes, then just give fluids. There's your treatment. If it's intrinsic AKI on the USMLE, check the UA. If the UA has sterile pyuria, you're thinking acute interstitial nephritis, also known as AIN. And this is a most common cause if there's recent antibiotic usage, changes in pharmacomedications, and now presenting with AKI and oliguria. If you check the UA and there's granular casts and epithelial cells, you're looking at acute tubular necrosis. And then if you check the UA and there's hematuria, you're thinking glomerulonephritis. For post-renal AKI, if you check the UA and it's going to be normal, it's usually indicating a urinary obstruction such as BPH. If you suspect dehydration is the cause of the AKI, then your next best step is to check labs. And so the BUN creatinine ratio will be over 20:1. The patient will be hemoconcentrated, which means that the hematocrit will be elevated. This is absolutely a slam dunk on almost every NBME. If you see a dehydrated patient, check their hematocrit, it will be elevated. And so for a FENA of less than 1%, the specific gravity of urine will also be over 1.020 for the dehydration as a cause of an AKI. Remember, dehydration is a prerenal cause of azotemia. Next, if the patient has a convincing history with physical exam findings indicating volume depletion, such as they have dry mucous membranes, a patient that has a history of poor PO intake, as well as an AKI, there is no additional testing needed. Just hydrate the patient. That's the best next step. The trick, everyone wants to select the next best step is a UA or calculate FENA. This is wrong in a patient that is clearly just dehydrated. An action potential mentoring test taking tip, if the question stem mentions dry mucous membranes, I highlight that immediately. It's a really helpful clue that a lot of students skim right over. Number 7. An AKI 1 to 3 days after coronary catheterization or revascularization procedure is contrast-associated nephropathy. And so to diagnose this, you have to have a high clinical suspicion, and the FENA will be less than 1% with muddy brown casts. The AKI will often resolve within 1 week. The only reliable way to mitigate and treat is IV sodium chloride or sodium bicarb infusion before and after the scan. Oral hydration has not shown clear benefits in these patients. A step 1 physiology integration. So contrast nephropathy AKI is due to prerenal vasoconstriction, and that will contribute to the FENA of less than 1%. And it also does have a component of direct tubular cytotoxicity, so it can cause an ATN picture as well with the muddy brown casts. So an important thing to note, drug-induced interstitial nephritis is usually due to antibiotics and NSAIDs on the USMLE. So how do you tell a difference on the USMLE if a patient received contrast and antibiotics or NSAIDs recently? So you look at the FENA and the UA. If the FENA is less than 1%, it's contrast-associated nephropathy. If the FENA is over 1%, it's drug-induced interstitial nephritis. If there's pyuria, white blood cell casts, or hematuria, you're thinking interstitial nephritis. And if there's muddy brown casts, you're thinking contrast-associated nephropathy. Number 8, recurrent calcium oxalate kidney stones refractory to dietary changes. What's your treatment? Well, the next best step is going to be to start a thiazide diuretic. This increases renal reabsorption of calcium. A trick question. It is recommended to actually get over 1.2 grams of calcium in your diet daily to bind oxalate in the GI tract and prevent stones. So you don't want to restrict calcium in these patients even though they have calcium oxalate stones. So make sure they get adequate PO intake of calcium. Some dietary modifications you can make. You want to decrease spinach in the diet. It's a high oxalate source. You also want to increase citrate in the diet with fruits and veggies. You can increase potassium in the diet, which would increase the urinary citrate excretion. You want to eat less animal protein, and this is going to decrease the urinary calcium excretion. So basically, in a nutshell, you want less urinary calcium excretion and more urinary citrate excretion. This will bind up the calcium so it doesn't form calcium oxalate stones. Number 9, if kidney stones are due to urease producing organisms such as Klebsiella or Proteus, you're thinking struvite stone. And so these will be magnesium ammonium phosphate stones. The urine will have a pH over 8 with coffin lid shaped crystals. The treatment for struvite stones is antibiotics with stone removal via percutaneous nephrolithotomy, usually required due to the large size. Symptoms. Patients with struvite stones will have a very large stone that prevents passage of the stone down into the ureter. And so classic renal colic flank pain is uncommon with the struvite stones. The symptoms are more likely to be fever, dysuria, frequency, and constant flank pain. So the renal colic flank pain, you're going to have struvite stones low on your differential because their pain is more constant. Important to note that staghorn calculi can also be seen with uric acid and cysteine stones as well. A lot of students forget that. Okay, so if there's an obstructing ureteral stone and a superimposed infection, what's your treatment? Well, the next best step is going to be antibiotics with ureter stent or percutaneous nephrostomy as needed. An action potential mentoring test taking tip. If they ask you for definitive treatment or a next best step in a patient that sounds unstable in the vignette, your treatment is going to be the ureteral stent and percutaneous nephrostomy. You definitely want to have those options in your wheelhouse if the patient sounds very sick or unstable. There are equivalent outcomes between ureteral stent and percutaneous nephrostomy, so both answer choices will not be an option. You pick whichever answer choice is available in the answer choices. A trick question that I missed. I thought you could actually do shockwave lithotripsy for an unstable patient with a stone and superimposed infection. However, that is for uncomplicated ureteral stones and may not lead to immediate resolution of symptoms. So if you need a faster resolution, you got the ureteral stent and percutaneous nephroscopy. Do not use the shockwave lithotripsy if the patient has a complicated stone. All right, a cheat sheet for management of ureteral stones on the USMLE. Step 1 is analgesics, antiemetics, and fluids. Step 2 is if there's a UTI, AKI, anuria, intractable pain, or vomiting, you want to do an inpatient admission and urology consult. If none of the above symptoms, you can manage them outpatient. And so if the stone is greater than 10 millimeters or the stone is not passed within 4 to 6 weeks, then you do an outpatient urology consult. All ureteral stones get alpha blockers such as tamsulosin if the stone is greater than 5 millimeters and less than 10 millimeters. If suspecting nephrolithiasis in a pregnant patient, your next best step is a renal or pelvic ultrasound. If that's negative, go for transvaginal ultrasound. If that's still negative but you have high suspicion, you treat empirically or magnetic resonance urogram or low-dose CT urogram in 2nd and 3rd trimester only. This far into the treatment algorithm tree is very rarely tested on step 2, but it can show up on step 3 occasionally. Don't get fooled by a negative CVA tenderness in a pregnant patient. The more distal stones will cause more of abdominal or labia pain. All right, number 12. Don't get confused here. Renal papillary necrosis is a very rare to cause AKI unless it's bilateral, but it will present with hematuria plus or minus flank pain in the setting of sickle cell or analgesic use. An action potential mentoring test taking tip. For all intents and purposes on the USMLE, if there's an AKI without hematuria, do not select renal papillary necrosis as the cause. This is one of those diagnoses that a lot of students just don't really know when to put as the correct answer. So if they have an AKI, probably not going to be renal papillary necrosis, but you definitely want to look for hematuria in the setting of sickle cell or analgesic use to clue you in. Next, renal colic pain with CVA tenderness plus an elevated BUN and creatinine. The most common cause is analgesic nephropathy causing renal papillary necrosis. So your next best step is going to be to stop the offending medication, and renal dysfunction will often self-resolve. A test-taking tip. Don't get tricked and choose ureteric calculus, as unilateral ureteric calculus will not cause an elevation in BUN and creatinine, despite the renal colic pain and CVA tenderness in the picture that really kind of makes it sound like a kidney stone. If there's elevated BUN and creatinine on the USMLE, you're not going to put ureteric calculus. It's going to be very rare to cause that unless the patient's got a solitary kidney or baseline CKD. Both ureteric calculi and renal papillary necrosis can both present with renal colic and hematuria plus or minus pyuria. And it'd be very rare to get like a bilateral kidney stones or kidney stone and a solitary kidney on the USMLE. Analgesic-induced nephropathy is going to have nephrotic range proteinuria, and there's no hematuria in analgesic nephropathy. Renal papillary necrosis, however, due to analgesics, will have hematuria. That's the big differentiator. So if you see hematuria plus you have analgesics, you're thinking renal papillary necrosis. If you see proteinuria plus analgesics, you're just thinking analgesic nephropathy. So two different things, two different presentations. The hematuria goes with the necrosis, so the renal papillary necrosis, and then the proteinuria by itself is just going to be analgesic-induced nephropathy. However, I have seen questions where they stated the patient had like 25 white blood cells per high-powered field, so this can be tricky to nail down the diagnosis. But if you look at, do they have hematuria, yes or no? If yes, then it's renal papillary necrosis. If no, you're thinking analgesic-induced nephropathy. That will get you the correct answer. The renal ultrasound is often going to be normal in these patients. So in summary, just one more time, if analgesics plus hematuria, you're thinking renal papillary necrosis. If analgesics plus proteinuria but without hematuria, you're thinking analgesic-induced nephropathy. Moving on to acute interstitial nephritis. The classic triad is going to be a morbilliform rash, fever, and eosinophilia. In real life, you're rarely going to see all three of these. It's like a 10% chance, but on the USMLE, they'll oftentimes give you the rash, fever, and eosinophilia. They will have white blood cell casts with tubulo-interstitial mononuclear cell infiltration. So that's going to be your T lymphocytes and macrophages. It's important to note that tubulo-interstitial invasion by neutrophils, on the other hand, is more common with infection, so pyelonephritis. Causes of acute interstitial nephritis include beta-lactams, PPI, as well as NSAIDs. It's almost always due to a new medication initiation on the USMLE. However, you can rarely see it with Legionella, tuberculosis, CMV, as well as rheumatoid disorders. AIN is a clinical diagnosis with labs. There's no need for renal biopsy. To treat, the next best step is to monitor creatinine with repeat labs after you discontinue the drug. It's going to self-resolve most times. If it does not rapidly self-resolve or the AKI causes worsening renal failure, your next best step is to give glucocorticoids.